Welcome, Dr. Wilds, and we want to introduce you. This is a wonderful program today. Welcome to the Mirowitz Center. Dr. Wilds is a hematologist, oncologist, and geriatrician. I'm not sure if I'm saying that right. She specializes in the care of older adults with multiple myeloma and studies fall prevention in older adults with cancer. She completed her medical degree, residency, and fellowships in hematology and oncology geriatrics at Washington University School of Medicine in St. Louis. She was on the faculty in Washington University as associate professor of medicine through November of 2020 and is currently serving as research consultant in geriatric oncology. Please welcome Dr. Wilds.
Thank you for that warm introduction. As was mentioned, I was previously at Washington University, and I am on what I'm calling my mid-career sabbatical. You may have read about healthcare providers leaving clinical care during the pandemic because of the waits, and I am one of those people. And I feel really blessed to be able to still use my knowledge and give you guys this lecture here today. So I'm going to move to sharing my screen. So as was mentioned, I took an unconventional step during my training to receive not only training in hematology and oncology, but geriatrics. And what led to that was during my oncology training, I met an 86-year-old woman who was diagnosed with an aggressive form of lymphoma. And by looking at her scans, I was worried that she was paralyzed because one of her tumors was near her spinal cord. And I walked into her hospital room and I asked her to lift her leg off the bed, figuring she might just have a little bit of muscle contraction, but really not be able to move that leg. And she kicked her leg up off the bed in a way that when I'm exercising, I can scarcely do those type of leg lifts. And it really got me thinking, wow, this 86-year-old woman clearly has a resilience, a robustness that her age alone is not telling me about. And I did some early research where, again, age was not really the factor. It was other medical issues that can accumulate during a person's lifetime, like other medical conditions, decline in function, strength, things like that. And so I did my geriatrics training to really understand those tools of a geriatrician in order to help combat some age biases about the care of older adults with cancer. So what we'll cover today is I'm going to talk epidemiology. Big word, it just basically means studying trends. Who gets cancer, what kinds of cancer, and talk a little bit about this intersection of aging and cancer and how the biology of cancer in some ways is influenced by aging. We're going to talk about the heterogeneity of aging, meaning every older adult is different, and that using age alone is really not going to be an adequate measure for a doctor to help determine what is the appropriate recommendation or recommendations that an older patient with cancer might be able to choose from. We'll talk a little bit about survivorship, which is the period after active cancer treatment, and then cancer screening. Now, this may seem a little backwards. It might seem more reasonable to talk about screening and then diagnosis and treatment, but there's an important reason for that. And actually, some of these same principles of aging are really relevant to decisions about cancer screening as well. So cancer truly is a disease of aging. The incidence of all of the most common types of cancer increases with age, with the largest age groups, so the largest proportion of patients being diagnosed after the age of 65. And along with that, most of the cancer deaths occur in people who are over the age of 65 as well. And so really, again, cancer being a disease of aging. And some of the reasons for that are simply due to why does cancer develop? Basically, cancer is a disease caused by our own cells over reproducing. All of our cells have both a gas pedal and a brake. Now, DNA is present in all of our cells, and it is what gives the instructions to our cells when to push the gas, when to push the brake. When there's damage to our cells that accumulates over a lifetime, that damage could occur in a place in the DNA that makes that cell die, and that can contribute to aging. But that damage can sometimes occur in just the right place that it takes the brakes off that cell, for example, in a breast cell or a colon cell. And then those would develop into cancers of the breast and colon, respectively. In addition, our immune system does contribute to suppressing cancer. We know this through a number of lines of evidence, such as people who've had organ transplants, like a heart transplant or a kidney transplant, are on medications that suppress their immune system. And those patients are at greater risk of developing some types of cancer. Now, with age alone and with the aging process, our immune systems change. The function of cells called lymphocytes differs. There are increased levels of chemicals called cytokines that are associated with inflammation. And that phenomenon is so prevalent that it's actually been given the name inflammaging. And that all of these factors contribute together to result in this increased incidence of cancer with age that we mentioned. Now, interestingly, as I mentioned, aging is a process of cells slowing down and dying on a cellular level to some degree, and cancer being the opposite, growing. So those seem to be a bit opposite, don't they? And on the cellular level, there are some factors of aging that are, in fact, kind of opposites from cancer. So, for example, there's a process called senescence. Basically, cells are not able to, in their natural state, able to reproduce infinitely. One of the mechanisms that helps with this is something called telomeres. So this is what a chromosome looks like. These are the packages of DNA wound up in our cells. And at the end, there's these little caps called telomeres. And basically, with every time a cell divides, it loses a little bit of that telomere. And it gets to a point where the cell says, okay, it's divided too many times. This cell is no longer a dividing cell. Unfortunately, though, while that mechanism would seem to be one that could inhibit cancer, because if the cell is no longer dividing, it's not a cancerous cell. Unfortunately, when cells become cancerous, they can actually make an enzyme that can make those caps stay on. And so the cell doesn't get the signal that it needs to stop dividing. Now, are cancers in older patients different than cancers in younger patients? There's actually a commonly held belief that cancers in older people are always slower growing. And unfortunately, that's not universally true. In fact, some cancers, acute leukemia being the classic example, can be more aggressive in older patients, tends to be more resistant to chemotherapy. In some cases, this is due to prior medical treatments that may have resulted in the development of a more aggressive strain of the leukemia. In breast cancer, for example, there's a little bit difference in the biology of the cancer itself. They tend to be more likely to respond to estrogen, which is helpful because then they can use estrogen blocking medications as opposed to conventional chemotherapy. So overall, most cancers at older age are pretty similar to the younger population with a few exceptions. So we talked earlier about these factors that converge to result in cancer being disproportionately represented in older adults. Add to that the aging of the population. By 2030, about 1/5 of the population will be over the age of 65. And with this increasing incidence of cancer in older patients, this is going to result in a great number of older patients who have cancer. And the reality is a lot of what we know about treating cancer are from studies that were designed to maybe not explicitly, but sometimes kind of accidentally really focus on younger patients. And a lot of the advances have really resulted in improvements in outcomes in younger patients, but on a one-to-one basis, those improvements haven't necessarily translated in improvements in the care of older patients. This can be because there's delays in diagnosis. A patient may not undergo screening. A physician may say, look at the date of birth on the record and say, oh, well, you're 75. I don't think the oncologist has anything to say to you or would have anything that you would want to take part in. So there are some biases, and then there's differences in the data that's available that has focused on younger patients. But I'm going to encourage you, if you ever encounter that kind of ageism, to challenge that. So this gets into kind of how doctors think about statistics. The average life expectancy in the US as of 2008 was 78 years. However, that is the average life expectancy from birth. So if a person lives to the age of 70, they outlive childhood accidents and things like that nature. A person who reaches 70 does not have an expected life expectancy of just 8 more years. And in fact, it's more dependent on what their overall health is like. So often when I am talking to a patient about considering their life expectancy, if we took the cancer out of the equation, I'll consult a table like this, which looks at a different life expectancy based on the health of the patient, divided by gender as well. So for a woman who is 70 years old, who's in the top tier of health, she actually has a life expectancy of 21 years. And so undertaking screening for a cancer for which treatment would help impact her both quality and quantity of life would be very reasonable. But contrast that with a person who's in the lower tier of health and may be expected based on heart disease, other medical problems, functional decline, frailty, and that sort of thing to have a shorter life expectancy. Well, that may impact one's thinking about screening for a cancer or what kind of treatment what that would be appropriate for that individual. So we really need to think that life expectancy is not a one size fits all. So let's talk about the heterogeneity of aging. Heterogeneity just meaning the big differences, wide ranges. This is a picture I clipped actually from the Shrewsbury newspaper some years ago when I was a fellow. This was a 86-year-old woman who was played tennis in Shrewsbury. And this is just a stock photo of an older gentleman. But, as you can see, chronologic age really tells us nothing about the overall physical health of these individuals. And a geriatrician kind of breaks down the different aspects of health that they're going to be considering into these categories. Function, which is how does one live one's daily life. The two of the most important measures of that are used by a geriatrician are the activities of daily living and instrumental activities of daily living. The ADLs are those activities that one needs to be able to perform to maintain their independence within the home. If a person requires help with their ADLs, these activities of daily living, which include bathing, toileting, transferring, dressing oneself, and so forth, they're going to be at high likelihood of either needing a full-time caregiver in the home or transitioning to some level of nursing care. The instrumental activities of daily living are those activities one needs to remain independent within the community. So this is things like using the telephone. Currently using the internet is not one of the IADLs, but I would argue that within a few years, it's going to be an essential component of maintaining independence within the community. So when that scale gets changed, all of you will already get your points for those. It also includes taking your medication, managing your finances, meal preparation, and so on. And so those are going to be kind of a combination, kind of the final end point of both having the physical ability to do those activities as well as the cognitive abilities to do things like finances, manage medications, and so forth. Now, performance status is a really crude measure of function that oncologists use, basically is 0 to 5 on one of the most widely used scales. 0 is absolutely no symptoms, perfect health. 1 has some symptoms. 2 is a bit more symptoms, but out of bed more than half the day. Grade 3, or I should say performance status of 3 means in bed more than half the day. 4 is bedbound, 5 is dead. So as you can see, this is a very coarse tool. This really doesn't tell us about the granular differences in function between patients. But unfortunately, for a long time, this has been the primary tool used. Most patients will end up in a 1 to 2 category. So you can see that we're really kind of got some big groups going on that aren't really going to help us refine our estimates of risk for an individual patient. So back to our geriatric principles, comorbidities are basically the list of medical problems, those chronic medical condition that an individual deals with on their day-to-day basis. Polypharmacy is the word for taking multiple medications. The cutoff used to define polypharmacy varies, but usually more than 4 or 5 medications is considered polypharmacy because there's increased risk of falls, interactions between drugs, adverse drug reactions, and so forth when people are getting into 6, 7, 8, 9 medications. Very interestingly, polypharmacy is absolutely rampant in older adults with cancer. And part of that is incurred by the oncologists prescribing numerous medications to help support them through cancer treatment, to help deal with side effects, and so forth. So real important for physicians to be aware of medications. And as an aside, those of you who've been to a doctor, you know that they often will go through the medication list. But honestly, I rely on my patients having an updated list, because so often the computer is not up to date. Medications get canceled out, or most commonly just left on there indefinitely. And so that is one thing I would empower you to do, is to maintain your own list of your medications, just to decrease the risk of these bad interactions and that sort of thing. So other common difficulties or vulnerabilities that we'll screen for in older patients with cancer, or just that a geriatrician will screen for in patients they're seeing, include depression, decline in cognition. So this may not meet full criteria for dementia, but there can be changes in memory and thinking that haven't yet really started impacting day-to-day life, that it's important for the physician to have noted. Oftentimes these these are subtle changes, and screening tests can help detect some of these early changes. Patients who've had falls, it's important to recognize this, because a prior fall is a strong risk factor for future falls. Incontinence is another geriatric syndrome to be aware of. And then it's increasingly important for the physicians to be aware of the patient's social support. If someone is having difficulty with their instrumental activities of daily living, they're going to need help with those, and who is it in their life that can help with those things. Now, if we take those geriatric principles and apply them in older adults who are facing decisions about cancer, it can help us individualize their risk assessment. As you know, risk is not a 0 or a 1. It happens or it doesn't. I should say, for an individual, yes, it's a happen or it doesn't, but we can try and estimate what an individual's likelihood of having an adverse event of treatment. And over 10 years ago, surgeons were recognizing that not every 75-year-old was alike. And if they looked at these geriatric vulnerabilities, they could identify people who were at increased risk for things like complications of surgery or staying in the hospital long. And those included the things I mentioned on the previous slide, things like being dependent in daily activities, reporting a lot of fatigue as a measure of just decreased resilience of their body overall, and spending more of the day in bed than out of it, were associated with increased risk of complications and longer hospital stays. Another term commonly used in geriatrics, but sometimes a bit difficult to define. There's actually still a huge amount of controversy in the geriatric and gerontology world for how to define frailty, which at least there's consensus in what it means. It's basically a decreased resilience to stressors. So obviously something like a surgery would be a big stressor. Less resilience would mean harder to bounce back from. And when the researchers looked at those factors that were predictive of postoperative complications, staying in the hospital longer, or needing to be transferred to a nursing facility after the surgery, being frail, in which this case they defined that as being weak by grip strength, not having a weaker grip strength, weight loss, exhaustion, low physical activity, or slow walking speed was associated with those poor outcomes of surgery. So what this led them to conclude appropriately is that an older patient should not be excluded from a cancer surgery just based on age alone, but really looking at these geriatric vulnerabilities in order to inform the patient and their family of what the risks of the surgery would be, to help them decide if proceeding with a cancer surgery, say if they were to have a colon cancer found, or so forth. Now, another approach to treating cancer is with radiation. So radiation is completed by using beams of radiation, which then results in the death of the cancer cells. It's typically isolated to a region of the body, say to the throat area for a head and neck cancer, to the breast area for a breast cancer, if it's felt that the patient is at high risk for the cancer recurring, say after a surgery. And in some cases, radiation can be used as the primary and only treatment for the cancer as well. When they've compared how patients fared after radiation, comparing younger and older patients, overall, the benefit from the standpoint of control of the cancer seems similar in younger and older patients. There may be a slightly higher risk of side effects of the radiation in older patients, including functional decline. So that is typically measured as those daily activities. People who may have been independent in activities needed some help during the treatment. But the hope is obviously that after they return to independence in those activities. Brain radiation can result in impairment of memory and thinking. So that's an important side effect that a radiation oncologist would discuss with a patient. Head and neck radiation frequently, unfortunately, can affect the salivary glands, and older patients are at greater risk for dry mouth. This may be also compounded by the fact that a lot of medications older people take do have dry mouth as a side effect as well. So I will spend a bit more time talking about chemotherapy, or actually I would call it systemic therapy. Most of the advances in treatment now are actually not traditional types of chemotherapy that were the hallmark of kind of the first 50 years of cancer treatment. More recently, we're using things like immune therapy, targeted agents, and an oncologist oversees all of those forms of treatment. So with conventional chemotherapy, it became clear around in the late 80s, early 90s, that age seemed to be associated with an increased risk of side effects. And when people started to kind of puzzle through why that would be, there are some physiologic, biologic changes in the body that can increase the risk of chemotherapy. Those can be things like changes in the kind of the proportion of the body that's water versus protein, and chemotherapy can be bound to the protein in the bloodstream. Kidney function naturally decreases with age. There could be an increased risk of drugs interacting with each other, like we talked about before. Another important consideration is that a lot of cancer therapies can reduce the good normal blood counts. And if the bone marrow, with age, naturally, a number of cells in the bone marrow decreases. And so there are fewer cells ready to regenerate after the chemotherapy. When a person needs to consider taking a systemic therapy or chemotherapy, an oncologist will meet with them and talk about the reason for it, what type it would be, and how long it would go on for, and that sort of thing. In addition to that, the doctor is assessing, okay, what about this individual patient tells me how hard that chemotherapy might be on this patient? What is their risk of side effects? And as I mentioned earlier, oncologists use this performance status, and certainly as a crude tool, patients with a better performance status tend to have a lower risk of side effects. But studies in the late 90s and early 2000s really started to say, hey, we can refine this better than this. And when they used these geriatric assessment measures, looking at things, those activities of daily living, cognition, and so forth, what they found is they were better able to predict which older patients would be at greater risk for severe side effects. Moving forward from there, a mentor of mine, Dr. Arthi Huria, conducted a study from about 2005, and actually it went all the way through 2015, where they followed 500 patients, older patients over the age of 65, who were going to be starting a series of chemotherapy. And her hypothesis was that a number of factors would help us understand which patients were going to be at greater risk for chemotherapy side effects. And those could include things like their age, that could include characteristics of the tumor, characteristics of the treatment, how intense was this treatment, what were their blood values like prior to starting the treatment, and what were their measures on these geriatric assessment parameters. As I mentioned, they enrolled 500 patients. Average age was over 70 and up into the 90s. When they followed these patients, they found that over half had one or more serious side effects. These are graded on a 1 through 5 scale. This meant that the patients had side effects severe enough that they might have needed to be hospitalized for them. When they looked, they found that the patients all had a range of vulnerabilities. Almost half had needed help with some of those daily activities. Almost 20% had had a fall. A small portion had cognitive impairment and so forth. And as I mentioned, over half had the serious toxicity of therapy. And what they found was that they were able to identify 11 different factors that were associated with an increased risk of that individual having severe side effects of chemotherapy. And that included the patient's age, the type of cancer, whether they started the chemotherapy at standard doses as compared to those who may have been started at a reduced dose. Polychemotherapy means, did they take just one chemotherapy medication, or did they take a combination of more than one medication? Were they anemic to start with? Was their kidney function poorer at baseline compared to their peers? And then these 5 geriatric assessment factors: had they fallen? Did they self-report that their hearing was impaired? Did they report that they had a difficulty walking 1 block? Did they require assistance in that instrumental activity of daily living, taking their medications? And did they report that their social activities had decreased? This created a score. And then when they looked at the patients with each of these score categories, you can see kind of this stepwise increase in the risk of having those severe toxicities of therapy. Those who had the fewest factors were only at about a 25% risk of a severe toxicity of chemotherapy. And those who had a very high score were at the highest risk of having a severe complication of chemotherapy. When they looked at that traditional approach to estimating the patient's function and whether they should, what the oncologist's perception of whether they should be offered chemotherapy was, this performance status scale, I'd mentioned a 0 to 5 one. There's also one that's 100 down to 0. But basically, you can see that it was useless in predicting which of these patients had severe toxicity of chemotherapy. Now, that model has been absolutely amazing. I've sat with patients and helped them make decisions, the right decision for themselves. We've moved from an era where the doctor says this is what we're going to do to one where we use what's called shared decision making. We talk through what our options are, and I help each patient find their best path. And I sat with patients and I showed them, your risk of having complications of this chemotherapy is 90%. And it allows them to say, that's not in line with my values. Being in the hospital is not something that I want to have to endure. And in them, their risk benefit ratio tipped towards not using that form of treatment. Now, these models are fantastic, have really been a huge advance in caring for older patients, but unfortunately they were done when most of the treatments offered were conventional chemotherapy. But as I mentioned earlier, a lot of the new treatments are not traditional chemotherapy in how they act in the body, in how they're administered. The newer drugs that are being approved seemingly daily to an oncologist, getting the FDA blast that there's new drugs approved. Well, I shouldn't say daily, weekly. It's either new drugs or drugs with new indications. A lot of them are what we're called targeted agents. Some of them are called immune therapy that harness the immune system. Some of them are pills and really targeting a specific kind of Achilles heel of a certain type of cancer. And by and large, a lot of them are better tolerated than the chemotherapy that was studied in my mentor, Dr. Hurria's work. And that also means that those same models are not applicable to helping a patient make a decision about their cancer therapy. So the work's never going to be done. As we get new treatments, we're going to also be helping make sure that we have data to present to our patients about what the side effect profile is like, what is their individualized likelihood of having that particular side effect, and so forth. And as an example of this and how well tolerated these types of treatments can be, former President Jimmy Carter had metastatic melanoma, which is the aggressive form of skin cancer. When he was 91 or 92, he was found to have cancer spots in his liver. And he received a form of therapy called immunotherapy that basically revved up his immune fighting cells to attack the cancer. And subsequently, his scans did not show any evidence of the cancer. Now, there's some debate. Most of us are pretty conservative about using words like cure, and it's usually something we'll often use more in hindsight than prospectively. And so while this headline is that he was cured, an oncologist perspective would be, we're not seeing any evidence of disease, but we're going to remain vigilant. If there were just a few cancer cells left behind that learn how to grow, we want to be aware of it and be monitoring those on scans. So to summarize the conversation about treatment, overall, age should not alone be used to say that a treatment is not an option. And the decision-making, whether it's about surgery, about radiation, or about systemic therapy, should really take into account the individual's overall health, what would their estimate of life expectancy be, their other medical conditions, these geriatric syndromes, and really importantly, what's important to the patient. Oftentimes, physicians get really focused on the idea that everyone's goal is to live as long as possible. And so often that correlates with a more aggressive form of treatment. But study after study have shown that that's not necessarily universally the case. A friend of mine, Dr. Enrique Soto, did a study where he asked older adults with cancer what their preferences were, and if they had to trade off between longer life and lasting impacts of their cancer treatment, what would they prioritize? And let me get the numbers right. 80% said that they would not want a treatment that left them with lasting problems with their memory or thinking, and 60% said that they wouldn't want to take a treatment that lengthened their life if that resulted in their having greater dependency, not being able to do as much for themselves as they would have previously. So it's really important for doctors to ask questions about what the patient prioritizes, and taking that into consideration when thinking through cancer treatment approaches. So now let's move from the cancer treatment phase to the cancer survivorship. And the reality is that there are some longer term considerations. Cancer survivors on long-term studies are more likely to report their health as poor and have functional limitations. Now, that doesn't necessarily mean that's all due to the cancer treatment. It could be that in the setting of their other medical conditions, those have resulted in these functional limitations and poor self-reported health. There may be some increased risk of psychological disorders, particularly depression and anxiety after cancer treatment. There are very real phenomenon of things like the worry about cancer recurrence and those sorts of things. And then the cognitive changes, chemo brain is a commonly used term for this. This is one that a lot of people have heard about. It's actually still relatively poorly understood. The studies are pretty hard to do because measuring memory and thinking it can be difficult. It has to take into account the patient's level of education, what was their cognition like before they started treatment. And so the best done studies are going to follow an individual long term so that they can be their own control, taking into account what their education was like before, what was their baseline testing like. Further, screening tests are relatively insensitive tools. Some of you may have had some of these screening tests because they can be done as part of Medicare annual wellness visits, and primary care doctors are sometimes using them. Usually they're a 10 to 15 item, remember a few words, maybe draw an item, that sort of thing. Those aren't going to pick up on subtle changes in memory and thinking, which an individual may experience after cancer treatment, but not show up on those testing. The really in-depth batteries of testing that'll really dive into memory, language, executive function, all these different domains, different areas of our brain that complete those activities, it can take 4 to 6 hours to do. So you can imagine that it's a very difficult study to do, to follow a person with 4 to 6 hours of testing over months or years. And so, but long story short, is that there is likely some interactions not really well understood, still an area of active inquiry to fully understand the impact of cancer treatments on memory and thinking. So I'm going to talk a little bit about cancer prevention. Special thanks to a couple of my colleagues from when I was at Washington University. We did a community talk on the 8 ways to stay healthy that Siteman Cancer Center puts out. And this is just showing the most common types of cancer. In men, these are prostate, lung and bronchus cancer, colorectal, bladder, and melanoma. In women, these are breast, lung cancer, colon, uterine, and thyroid. And the contributing factors to these are a broad range. Tobacco use being one of the greatest, but a number of other lifestyle type factors that are what we'd call modifiable. Things we can do something about can include obesity, environmental pathogens, things like viruses. Physical inactivity is considered a risk factor for cancer, poor diet, and so forth. So we're going to go through some of those that are the most actionable. It is estimated that 1 in 3 cancer cases can be prevented with lifestyle modification. So the approaches to this will include maintaining a healthy weight. It is known that obesity is a risk factor for a number of cancers. The largest increased risk is in uterus cancer. cancer, which is likely related to the fact that the fat cells, the adipocytes, actually make estrogen. So it creates an increased estrogen category, which can stimulate the uterus growth. But other cancers in which obesity is a risk factor include the stomach, gastric here, liver, pancreas, kidneys, a type of brain tumor called meningioma, multiple myeloma, the cancer that I treated, and so forth. This is just more evidence that being obese not only increases the risk of the cancer developing, but also increases mortality after diagnosis of the cancer. And unfortunately, it's not just in the US, but throughout the world that obesity is an increased risk for cancer. As I mentioned, there's plausible biological reasons for this, which includes that the fat cells themselves are actually biologically active. They are making chemicals that create a setting of inflammation that can directly impact kind of creating a permissive environment that a cancer cell might be living in. Regular exercise is also a potential way to decrease the risk of cancer. When they look at people who are more physically active versus less physically active, a number of cancers here have been shown to have a lower risk of those cancer with regular physical activity. And how much and what kind of exercise? Well, in general, what's recommended is following the US this is American Cancer Society guidelines for nutrition and physical activity. But actually they mirror the US Preventive Services Task Force as well, which is that an adult get 150 minutes of moderate intensity or 75 minutes of vigorous intensity activity each week. So what are some examples of moderate or vigorous activity? So moderate activity would be things like a brisk walk, heavy cleaning, using a power mower to mow the lawn, light effort bicycling, badminton, doubles, tennis. Vigorous activity could be hiking, jogging, shoveling, fast bicycling, and singles tennis, etc. So unfortunately, many of us are sedentary. It's hard to get up and get moving. I did manage to this morning before our talk. I did get on the exercise bike and got some 30 minutes in. But 60% of the adults in the US are not regularly active. And certainly the COVID restrictions have made that more difficult with if one previously worked out at a gym. I absolutely saw that with my patients through the first lockdown, people who had previously really enjoyed making it to Silver Sneakers, YMCA, and so forth, who had restrictions on that, basically became incredibly sedentary. And so it's understandably, this is a difficult one to make a dent in, and especially when it's hot and humid and our outdoors aren't necessarily a great place to be getting our physical activity. But hopefully the fall is coming and we can get outside and enjoy the changing colors and so forth. So how can exercise impact? How does moving my legs decrease my risk of a breast cancer, for example? A lot of benefits of exercise, as you can imagine, enhancement of immune function. We talked earlier about how our immune function can help with surveillance for cancer cells, kind of normalizing the sex hormones in men and women, improving how our body uses our insulin and sugar, decreasing the risk of obesity, and that sort of thing are all potential mechanisms by which increased physical activity reduces the risk of cancer. This one hopefully requires the least comment. Smoking is obviously the #1 cause of lung cancer and a number of other cancers, but quitting now, even after many years of smoking, immediately starts to decrease the risk of cancer, and the lifetime risk drops by about half within 5 or 10 years. Of quitting smoking. So there's benefit even after years of smoking to quitting. Healthy diet is associated with decreased risk of cancer. Now, what constitutes healthy? There's always some new fad to follow, but the most consistent data has been basically what is essentially like a Mediterranean diet, decreasing the amount of red meat, increasing the amount of fiber, limiting fast foods and sugary drinks. Increasing fruits and vegetables, and so forth. This is essentially reiterating the same, decreasing processed meats, 2.5 cups of fruits and vegetables, whole grains over refined grains, and so forth. There's a lot of interest in intermittent fasting as a potential mechanism. Does it have any impact on cancer incidence? Data here needs to mature. The research on this is still developing. But what is known is that a lot of the biological impacts of intermittent fasting actually kind of line up with what we would anticipate would ultimately reduce the risk of cancer. Intermittent fasting doesn't need to be days at a time. It can be just setting a time period during which one chooses to eat. And there's different they make it more complicated than it is. Ratios of 16 hours to 8 hours, 16 hours fasting, 8 hours eating. It's simple. I've done it. I basically sometimes when I have chosen to do this, will only eat between 11 a.m. and 7 p.m. And that's all. So rather than making it real complicated with ratios, it's just that I eat during that time, and then I don't really restrict when I'm eating. I just listen to my body. Alcohol is a potential carcinogen in some settings, and the recommendation from the cancer prevention standpoint is to just drink in moderation. Alcohol does increase the risk. Alcohol can increase the risk of heart disease, stroke, blood pressure, lots of things, and is recognized as a carcinogen by the World Health Organization and is associated with a number of cancers. Including breast, colorectal, liver cancer, and so forth. As I mentioned, these are the types of cancers that are associated with alcohol ingestion. Now, the flip side of that is a lot of people hear about red wine and its potential health benefits. Not really clear what its role in the cancer prevention setting is. And experts have basically said, if thinking from the cancer prevention standpoint, the healthiest option is abstaining, but if one chooses to drink alcohol, red wine may be the healthier option. But they don't recommend starting drinking alcohol if one was not previously drinker, simply for the health benefits. So protecting oneself from the sun is going to be another important consideration in preventing cancer. There are 5 million people treated for skin cancer in the US each year. Some of those are not cancers that would typically be expected to be life-threatening, but melanoma is a potentially fatal cancer in its likelihood of spreading. Sun damage accumulates over the lifetime, and I, as a child of the 80s, certainly knew nothing about protecting myself from the sun, honestly, until I got to medical school. And so there's, decades over which many of us will have accumulated sun damage. And with the increasing life expectancy, that's going to be a greater time period over which individuals can accumulate that sun damage. Skin cancer screening is an area that it's a little indeterminate about whether screening can prevent progression to more severe cancers. The U.S. Preventive Services Task Force tends to be a little bit conservative on their recommendations, meaning they don't make a recommendation unless there's strong evidence that screening for something is going to impact the likelihood of future problems. So they don't currently. What skin cancer screening would be going to a dermatologist, having kind of a head to toe skin check over for any early lesions. Whether or not one does, being aware of one's own skin, seeing spots, being aware of things like changes in shape, color, spots that bleed. This is a melanoma, and it has the classic A, B, C, D features. Asymmetry, meaning you can't draw a line through it and fold it in half. Border irregularity. C is color, so the dark color, and diameter here is at a centimeter, all worrisome for a melanoma and appropriate to be checked out. So ways to protect yourself: stay in the shade, especially between when the sun is at its highest point between 10 and 2. Use sunscreen, wear a wide brimmed hat, clothing covering you from top to bottom, long sleeve shirt, and so forth. So just a fun little exercise. I went through and picked out what's right with this stock photo I found on seniorlifestyle.com. Well, great. They've got an umbrella. She's wearing long sleeves, and I'm going to give him half credit for the hat, but it really ideally would be a full brim to cover those tips of the ears that tend to get a lot of sun damage over time. They could be doing a little bit more for their sun protection. She's not wearing a hat. I don't see a sunblock bottle visible, and sunblock needs to be reapplied after swimming in every 2 hours. And then lastly, for this St. Louis audience, I think that's a Cubs hat. So another thing wrong with this picture. So number 7 on our list of ways to prevent cancer, including protecting yourself from sexually transmitted infections. I have a dear friend who is an expert in sexually transmitted infections. We did residency and she is an infectious disease expert. And she says age is not a condom. And it's important to remember that there are infections that are associated with increased risk of cancer. The human immunodeficiency virus has a number of cancers that are increased in prevalence in individuals who have contracted HIV. And the human papillomavirus is associated with both gynecologic malignancies, as well as really kind of an epidemic of oropharyngeal tonsil type cancers as well. All right, let's talk about screening tests. So there are cancers, the most prevalent cancers are those for which we have the best data for screening. So colon and rectal cancer, cervical cancer in women, breast cancer in women as well. And then in some specific subgroups of people, such as longtime smokers, there are studies that indicate that screening for lung cancer with low dose lung CTs can help detect very early cancers that can be removed. So let's talk about kind of the principles behind screening. What's the idea? Well, this is a bit intuitive, but let's walk through it. So the idea is that you undergo a screening test. It's a positive test when a precancerous or cancerous lesion or early cancerous lesion is detected, and the spot that's seen on the scan truly is a cancer. After a biopsy, then the individual undergoes treatment, which then prevents them from dying from that cancer, resulting in longer survival. So that's kind of the rationale behind why screen for any cancers. However, it doesn't always work that way. So this is how it gets a little bit difficult, and it's not easy to just make a postage stamp on it. There are some individuals for whom it may be appropriate not to screen for cancer. And why would that be? Well, what if the screening test is not that great and it results in a fair number of false positives? There can be harm of that. It can cause worry, it can cause anxiety. If a person undergoes a biopsy of a false positive, there's risk to procedures, bleeding, pain, discomfort, not to mention, potentially even more serious for things like a lung biopsy. There's cost, there's anxiety associated with all of those. And what if in some individuals, most likely the scenario is an individual who has other conditions that may be limiting their life expectancy. If that person undergoes a screening test, goes through this whole process of a biopsy and goes treatment, but it doesn't impact their survival, screening may not have been appropriate for that individual. I had a patient some years ago with a blood cancer called multiple myeloma. On average, patients with that cancer live for 5 years. In some cases, actually, the data is a moving point because the outcomes of that cancer are improving with all of our advances. But at that time, it was about 5 years. She had actually been on her cancer journey for a couple of years, probably three and a half, and her cancer was actually behaving a bit aggressively, and she wasn't having as long a periods of cancer control with each successive line of treatment. Towards the last probably 6 months of her life, she came and was happy to report that she'd undergone her mammogram. And I accepted that information, and I didn't say anything further on it. But the reality is this woman undergoing a mammogram, screening for a breast cancer that even had she had a small, clinically insignificant breast cancer, this cancer, the cancer that I was already treating her for, was clearly going to be the more life-limiting issue than a previously undetected cancer. And she had to go through all of that. So there are some settings in which screening is not appropriate. That's a rather extreme example, and most patients are probably in more in a different place than that when considering their screening. There is a lot of controversy. Well, I shouldn't say controversy, just differences, different perspectives among different societies about whether there is an age point at which cancer screening for certain types of cancer should not be categorically recommended. I mentioned the U.S. Preventative Services Task Force. They actually put upper age limits on screening for a number of their cancers based on the fact that the original studies done to determine that it benefited patients for them to undergo cancer screening in these settings were done with age restrictions. And so they use those data to give these age restrictions. Now, I would say most physicians will look at this in a little bit broader context, such as those used by the American Cancer Society or the American Geriatric Society, which say, let's really think about the patient's overall health. What else is going on with their health that might impact what we do if we find something with one of these screening tests. And so my 2 cents is basically the discussion really needs to be individualized between the individual and their healthcare provider, thinking 2 steps down the road. What would we do if this test showed something? If there is a small cancer there, what would that look like in the context of someone's overall otherwise health? As I mentioned earlier, a 70-year-old woman in the top tier of health has a 21-year life expectancy, and a small cancer at that stage is going to much greater likelihood of impacting her healthy life expectancy, and almost undoubtedly would appropriate to detect and address. So to summarize and leave us a few minutes to chat here this morning, as I mentioned, the incidence of cancer increases with age. And with the aging of the population, there's going to be a tremendous growth in the number of older individuals facing a cancer diagnosis, and that age alone should not be used to dictate treatment, and that there is increasing evidence that using the principles of a geriatrician to help inform decision-making can really help and refine estimates of risk, and that whether it's treatment or screening, individualizing those discussions based on the individual's health really, I think, is the way to proceed in incorporating the individual's preferences about their care and values. So thank you so much for your time, and looking forward to chatting here.
So, Dr. Wilds, there was a previous, while you were speaking, from Rabbi Shulamit, is skin cancer more prolific over 70, and how is it treated?
Great question. So the 3 most common types of skin cancer are squamous cell carcinoma, basal cell carcinoma, and melanoma, thankfully being much less common. The first 2 are typically removed with a local excision. It can, depending on the size of the cancer, could even be done as an office procedure with local anesthesia. And the either dermatologist, or in some cases, if it needs to be a surgeon in other situations, then they just simply remove it. And it's examined underneath the microscope. And if all the edges are free of the cancer being present there, then that typically is all the treatment that's required. Melanoma is a much different situation because it can be much more aggressive and have a greater chance of spread. It is also resected by a local excision. Its depth of invasion is very important. And then there are algorithms based on the depth and how many of the cells are dividing, and how big it is overall, whether that person is at greater likelihood of the cancer recurring. In some cases, people who've had a fully resected melanoma will be offered a treatment afterwards to try and prevent the cancer from showing up elsewhere because of that risk. So did I cover what you were hoping to hear? Oh, and answer, is it over increased likelihood over 70? Great question. Yes, it's going to be increasingly prevalent with age because of the accumulated sun exposure over the lifespan.
And then there was another one. Will you be educating MDs in the St. Louis area with these amazing facts for seniors?
Oh, thank you for asking. Yes, I've tried. While I was at Washington University, I certainly worked on this on a couple of fronts, giving grand rounds to the physicians, educating our young doctors in training, which I think is a really important place to kind of be spreading the word, so that I could be equipping them when they leave St. Louis and go into their own practice. There's actually a really vibrant community of geriatric oncologists, both nationally and internationally, that I'm involved in, and we've been able to coordinate with some groups that work on creating education. So the American Society of Clinical Oncology is the national U.S. organization, something like 40,000 physicians, and thankfully they really have bought in with us on this, and they have educational material online that doctors can go in and listen to lectures or read articles to get kind of additional education on to learn about using these tools. I've worked with a community cancer group called ACCC, and they are kind of trying to aggregate the tools for oncologists to use. Part of the trouble is these aren't we don't get the attention of drug companies who can make a splashy layout of their fancy new drug that improves survival and things like that. There's not a FDA approval for using these types of tools, and so you're absolutely right. It's been a little bit harder to get the message out than it might be in a kind of with a fancy new medication or something.
Thank you.
Can't hear you. Can you hear me?
Yes.
Okay, my name is Linda, and I'm a 33-year survivor of non-Hodgkin's lymphoma. I've gone through treatment 9 times, radiation and chemo. And 8 years ago, when I was 71, I saw a doctor about a stem cell transplant. And he wanted to do it. And I said, I think I'm too old. And he said, we don't look at the age, we look at the patient. And I had an autologous transplant, flunked it, didn't like my own stem cells, but here I am 8 years later. So don't let anybody think age should stop you from anything.
I love it. That's so great, because actually it was autologous stem cell transplant that was my first research study back when I was a baby doctor that really got me going down this line of questioning. I went to one of the senior doctors at that time. This was about 2005, and I said, I need a research project. And he said, it seems like older patients have a harder time with this autologous transplant. You need to study it though. We need to figure this out, if it's just his perception or if that's what the data showed. And what we showed was that it wasn't age. It was that on average, older patients tended to have more comorbid medical conditions. But when we kind of did the fancy statistics to kind of parse out, was it age or was it additional medical conditions? And so, like your doctor said to you, hey, this is not about the chronologic age. This is about how much the aging. Oh, Judith, if you're speaking, we can't hear you, Judith. Which is strange because you don't appear to be muted on our.
All right, does that help?
Does that help?
Yes, there you are.
Okay. Well, I was just making a comment that if anyone had any questions, that they could unmute themselves, ask a question, or type a comment or question, raise your hand, any of those options to ask a question or make a comment if you'd like. It's a lot of information, Dr. Wilds. I think it might take a little bit of time to process.
I was afraid of that. But I couldn't cut everything I wanted to wanted to hit all of it.
I appreciate it very much, very, very much. And if there was a question that came to mind at a later time, if they wanted to ask you, do you want them to contact me and then I respond to you, or do you have an email that you would be willing to share?
Sure. I can give my email. I'll type it here in the chat. That may be the easiest.
And then I can email it. I will be also emailing a copy of the recording in case anyone wants to share it at a later time. And when I do that, I will include the email contact for Dr. Wilds in the event that you have something that comes to mind later.
Right. With the big asterisks, you need to talk to your own doctor.
Yeah,
This
yeah.
is not medical advice. all
General
that, but
questions, very
yes.
general questions about about the about the program today.
There we go.
Okay. Well, thank you everyone for participating today. Thank you so much, Dr. Wilds. We really appreciate the wonderful information that you shared, the hope and just the thinking process of aging. We really appreciate everything that you've shared today, and we just want to greatly thank you. So if anyone doesn't have anything else at this time, thank you again. Thank you everyone for being here today, and we will say have a good day.
Take care. Bye.
Bye.